Today we're with Dr. Frederick Carrick, or better said, Professor Dr. Frederick Carrick. He has been my teacher for a big part of my life. He is a professor of neurology at the Carrick Institute, but also at the Central Florida University, and he's a senior research fellow at Cambridge for Mental Health. He's the founder of Carrick Institute, and he's the founding father of functional neurology, which we talked about in a previous episode. Today we will basically discuss your paper on eye movement training and acute stroke, middle cerebral artery stroke. And we just want to ask you some questions about it because it may be very interesting for future rehabilitation purposes.
Well, perfect, and it's good to see you in Cape Canaveral, Florida.
Thank you. First of all, we're interested in how did you become so incredibly passionate about neurology, helping people with neurological problems?
Well, I think passion really hits the things that we do when we're in the service of others, and neurology is so encompassing. No matter what you think, no matter what you feel, no matter what you want to create or experience, it all comes down to a central aspect of your brain function. And as a clinician, I would see patients that have injured their brains don't work as well as they could have, or maybe a child didn't do so very well in school. So from a clinical point of view, we knew for many, many years, well, for centuries, that we needed to do things to assist the nervous system. And as a consequence of that, we need to study and develop research so that we can do it better. And the more we know, the more passionately we embrace the fact that we need to know more. So I think that's pretty well a summary of my life's work.
Yeah, great. Now on to your research paper on eye movement training. It's quite novel. I have not seen many, if any at all, papers on the subject of eye training with stroke patients. Can you tell us a little bit how you set the study up and how you conducted it?
Yeah, I'd be pleased to. We presented the results of this study at the International World Congress on Stroke, so we've had a lot of attention to our work. And I'll just dial back about what the study is and how it came to be. It came to be because so many people have strokes, and everybody has got a little cross or an epidemiological aspect of how many people will have a stroke. It's epidemic types of proportions, lifestyle, diet, injury, genetics, everything comes into it. Strokes are largely preventable if you have certain modifications in your life and your medical type of status. Unfortunately, I see people after they've had their strokes. We see, of course, people that you meet in your family every day, and who's going to have a stroke or not? Well, we've got some ideas now of who might have them. But what do we do when people have a stroke? They are debilitating to people's lives, to society, to their families, such that people lose that part of themselves oftentimes. And it's different than just having posturing or not being able to walk or speak or think. It affects so many parameters that we could really speak for a lifetime about the terrible consequences of stroke. I am dedicated to decrease those consequences after one has these accidents. So we had, for many years, or in my personal experience over the last 40 years of clinical practice, have seen people that have had stroke, and we've done different things. We need to do different things to rehabilitate them so that they can embrace something in their life which will make a difference. And we found certain things that seem to work better than other things that we did traditionally. This is an ongoing process. So what we wanted to do is to find out whether an intervention that we can make in someone that's had an acute stroke, which means to say they've had their stroke, they're in the hospital, they're in the intensive care unit, can we do something immediately at that time that would make a difference in their outcome? So that was the question that we had. There's not a shortage of people that have strokes to study, And people that have strokes are very willing to enter into a clinical trial to see if we might be able to help them. So what we found was that in regards to brain function, there are certain things that affect little parts of the brain. For instance, if I move my finger, that affects a little part of the brain. If I touch someone, that affects a part of the brain. If I give someone a drug, that affects the brain. But one thing that really affects the brain pretty majestically are eye movements. The ability to move your eyes from side to side or up and down involves a very complex interaction of basically all areas of the brain and the visual system. So we had developed in clinical practice the utilization of eye movements in different brain disorders. I had seen patients that had what we call dystonia, which are contractions of muscles that are not something that a person wants to have. And I developed some strategies where I would give different eye movements specifically to activate areas of the brain that were very successful in decreasing these types of aberrant movements. I also had patients that had traumatic brain injuries in sports, and I developed different types of eye movements specifically for them, and on it would go. With stroke patients, I developed some different eye movements that worked very, very well in rehabilitation strategies after the person had a stroke. So the question was, what if we took those things that work in people after they've had the stroke and immediately start to treat them when they've had their stroke? So that was the basis of the experiment. And what we were able to do in the hospital was we did what we call age and sex match controls, which means to say that when a person came in that had a stroke, and if they were 50 years old and they were male, we would put them in a group. We'd have another one that was 50 years old and male. We put them in another group. And we treated all of them with the greatest kindness and the upward standards of medical care, which we gave them everything they needed. In other words, the type of study we wanted to do wasn't taking away anything that could help them, but was adding something on to one group and not adding it to the other. And then we compared the outcomes of what would happen. So here's what we did. We know that people that have left-sided strokes largely will have what we call posturing on the right side of their body. They usually lose speech. They have different types of problems that are different from people that have strokes on the right side of their brain that have problems largely with the other side of their body, or the left side of their body, and some different cognitive, emotional types of things that happen. So we looked at people that are having acute strokes, identified the stroke, and we confined our study to infarctions, which means that you're not getting blood supply to an area of the brain in the territory of the middle cerebral artery. And that's a very common area of strokes. A lot of people will have these. We use an infarct model. There's two different types of stroke. One is a hemorrhage, where we destroy parts of the brain because the blood will come out of an artery. The other is decreasing oxygen and fuel supply. Those are the ones that we looked at, the ischemic type of stroke or an infarctive stroke. Once we identified that people had an acute stroke, they were put into one of two groups. The one group was given specific eye movements that were aligned to affect the area of the middle cerebral artery. We know that very well. And the type of eye movements that they would do would be such that we were able to put them in a scanner, give them the eye movements and reverse it in a mirror so we could watch their brain as they're doing it. And they would do these eye movements for 3 minutes, 3 times a day, that's all. And they very specifically would follow a ball, and they would go and appear, and they would just move their eyes to the target and then follow it. It wasn't very difficult for them to do. They had to be conscious. People that had strokes that were unconscious couldn't participate in the study. Majority of people that have a stroke are conscious if there's some viability, and we did this and then we scored them. And we use standard scoring that we use on all patients. We call them Glasgow Coma scores. We have other scores that we look at, which are National Institute of Health stroke scales that are translated into every language around the world. It's a common type of activity. And then we used different imaging, and we used EEG, where we put electrodes on the patient's head, and we looked at the different spectrums or frequencies, how fast the brain would fire. We did this, and we were very, very pleased for many reasons. One thing that was very evident was that the individuals in the active treatment group that did the eye exercises, they didn't have the posturing or spasticity, whereas the ones that didn't do those, they did, which means after their stroke, the ones that survived would have their arms and their legs didn't work as well as they did before, whereas the ones that did the eye movements had much greater movement. That was amazing for us, because it was something that when we look at rehab, getting someone to use a hand after they've had a stroke is very difficult to do. We were able to address it immediately, and it was a marvelous type of an outcome. But what we found were statistically significant improvements in the stroke scale that is used around the world in the individuals that did the treatment, whereas the individuals that didn't do it, the standard medical care, didn't have those improvements. In fact, many of them did worse. So we knew that we had something. The EEG changes were very, very dramatic and statistically significant, where we looked at different power ranges and computations that you can see. It's a little complicated, but at the end of the day, what does it mean? It means that the brain activity was better or improved in individuals that did the eye movements. So at the end of the day, we had a therapy that costs nothing. That is to say, a patient can do it in concert with all the other therapies. It's 3 minutes, 3 times a day, and it makes a significant difference. So there's no extra charges for the people. There's nothing that they have to take. There's no additional medication. There's no side effects. There was no consequences that are bad about it. The patients liked doing the exercises because they found that they had a significant difference.
Eye movements.
Yes. So eye movements they're beautiful. They allow us to do so many things. They really allow us to walk. I'll give you an example. If you've ever been in a fun house where things are moving back and forth, you're going to walk very, very slowly. Or if you get up in the middle of the night to go to the bathroom and the lights aren't on, you walk very, very slowly. We know we need to see, and we need to be able to take our eyes and move them onto a target or something that we want to see. And this is very important to allow us again to move, but it's also very important for us to be able to sit still and be able to see other things that are moving. As a consequence of this, just in the development of humankind, there has been so much brain activity that has been dedicated to these eye movements. In fact, the movement of eyes and the visual system interplay involves the entire brain. So if there's an area of the brain that is of interest, there's an eye movement or a visual substrate that's associated with that. The thing that's important to clinicians around the world and to people is that eye movements are also diagnostic windows of things that go wrong with your brain. So your brain is involved in all of these complex things, but also your doctor can look at the eye movements and find out that if they're not doing things exactly as they should, that there can be a problem. For instance, everyone knows about runners that are in a race. They can be sitting on your mark, get set, and off they go, watching the Olympics. Well, the eyes are like this, so that when something comes into your visual field, or you hear the roar of a lion, or you hear the honk of a horn, your eyes have to move to that target. And the speed with which they move, which we call the latency, is something that has been linked to problems with Alzheimer's, with Parkinson's disease, with head injuries. And there are just an infinite number of things like that that we can measure. And fortunately, in 2019, we've got computers and instruments that give us numbers that allow us to measure things that we couldn't measure at the bedside 500 years ago or 1,000 years ago when people were looking at eye movements historically. So now we have what we refer to as empirical data, which allows us to compare the movements of eyes when people have a problem in their brain to their movements of their eyes after they have a treatment or a drug or an activity, so that we can say whether the treatment was successful, non-successful, or whether it was harmful if the treatment was bad for you. So eye movements are things that allow us to quantify brain function. They allow us to measure the effects of individual treatments. They let us look at the progression of diseases. For instance, in an Alzheimer's patient that is unfortunately losing their abilities to use their brain as they could, we can measure the decline or the rate of the decline, and this allows people to prepare for assisted living, for other things, for changes in the family structure, for future types of planning. It really is a beautiful concept of things that we can do clinically. From a research point of view, we have both human and animal models that we can test in regards to certain diseases, whether they've been genetic from Huntington's disease on down, that have certain characteristic eye movements. I guess one could say that for every disease that you can imagine, there's a specific eye function that's associated with it. We know so much of this now, but the really exciting aspect, I think, for humankind and society is that we hope to know a lot more tomorrow and continuing on. So a great area of research around the world in many labs and many clinics. It's really hard to talk a little bit about something that is so big, but I think that gives you a little bit of a flyby of what we would look at in regards to eye movements.
Yeah, that was a very clear, concise explanation, and we
Oh, wow,
look
good.
forward how powerful they are.
They are,
Yeah.
yeah.
So, with respect to the first study then with the eye movement training, will there be a follow-up, or are you thinking about new research in that arena?
Well, there's always follow-ups that are ongoing. The problem we have with research is funding. These studies are very expensive, and there's only so much money that goes around. So we are involved in continuous research, and we've done many publications in regards to head movements, eye movements, vestibular activities, and very, very specifically in regards to head injury and in mental health, in cognition and thinking and degeneration. So we have this ongoing. I'm presently involved with animal studies where we are looking at different movements of eyes and targets and their brain functions. So the answer is yes, research is ongoing. Yes, it's very expensive. Yes, we need some more money so that we can do more things to help more people. And it's exciting with collaborations throughout the world.
Yeah. So and this is still the eye movement training with any disease that you were already mentioning is quite novel. It's not done that much yet, but I'm sure there will be more done once more gets out.
Yeah, it's becoming very popular after our studies. I mean,
Yeah.
people, almost everybody that's working with brain is doing some of it.
Yeah.
Some of them at a better level than others, but I think I think you can be pretty well guaranteed that if you're looking at somebody treating in a contemporary brain clinic, that you're going to be looking at some sort of eye movement therapy.
Certainly with traumatic brain injury and stroke.
Sure.
Are there any other completely novel therapeutics that you are looking into at the very moment for traumatic brain injury, stroke, or other mental diseases? That is very exciting.
Yeah, we have a lot. Not little things, but big things. Kids need to learn to read in order to gain knowledge and mature their brains and be socialized. But kids that have alexia or they can't read well, when they move their eyes from word to word, their eyes sometimes skew and they can twist the words and they can have a problem interpreting. So we're doing some very active research in regards to that with some pretty phenomenal types of activities. We're presently involved in some major studies in regards to eye tracking, where we're looking actually at the movement of the eyes. This is being utilized and has been approved by FDA on the field, where a person, not even a doctor, can hold up a card of different numbers and look at the speed that it takes someone to read them and a variety of other types of activities. So there's a great excitement. We're finding that there are apps that are available on iPhones and smart tablets and things that allow people to do these things themselves, and with direction they can do some marvelous types of activity. I can tell you that there isn't a moment that goes by that I don't get a call from some clinician or researcher saying, hey, we'd like to look at this, what do you think, can we do it? And yeah, we can do it, but when can we do it is dependent upon, again, our resources, our talent, our investigators, the doctor's time, the clinical space, and funding. But it's an exciting world, and we're dedicated to understand a little more of it.
Thank you. Just to wrap things up, how do you see the future of the management of neurological conditions? Because it's very obvious things are rapidly changing into new directions. How do you see it yourself?
Well, the future is sort of cloudy. We can't see through it. I mean, that's the reality of it. But here is the reality. We have an opioid epidemic throughout the world. And that is really, basic plain neurology, whether it be the perception of pain, of things that, are unpleasant, or whether it be pharmaceutical consequences for people with mood disorders, a variety of other things. We've got big problems with drugs in our society. People like them. We've got terrible problems in the Western world, in Europe, the United States, Australasia, very specifically to illegal drugs or fun drugs that people can take and damage their brains, as well as people to get addicted to drugs for a variety of different reasons. So one of the big futures of neurology is to develop mechanisms that are not associated with a drug that could be addictive, for instance. So there's been a big push to look at pain controls that are non-opioid. For instance, there's a big push in neurological education to teach children that, well, you shouldn't smoke and you shouldn't do cocaine and you shouldn't do bad drugs. That is a big, exciting future of neurology that is necessary for our society. The other things that are important, I think, on the field of neurology is preventative neurology. How do you know if you're going to have Alzheimer's? Well, there's some different things that say you might, but how do you know if you might be able to do something to prevent that Alzheimer's? Well, we think that we may have some preventive activity that could involve diet, exercise, different therapies, and we think a lot of these therapies are fairly easy and inexpensive to do. We know, for instance, that doing Tai Chi exercises really works well in Parkinson's disease treatment, but we also think it works well in preventing the expression of it. So I think personally in neurological research, the concept of maximizing human potential, maximizing your brain activity to allow you to think about things, to be able to read a book and then to remember what you read is very important. So learning strategies are important. Changes in education, the way we teach students to learn is based upon neurological principles, so that when we look at something, we want to be able to study it in school, but then 10 years from now, 20 years from now, be able to know what we studied, not study it, pass an examination, and then have to learn it again and again and again. So memory, strategies for thinking, learning, applications, happiness is all in the future, I think, in neurological research, and that seems to be the thread that I'm following, at least, and I think many other people in society are following.
Thank you so much. It was
It's so great to see
a
you.
great interview. Yes.
Super.
So if any of the audience wants to learn more, they can go to the carrickinstitute.com
Sure.
or to look up your research, F.R. Carrick. And I don't think there's anyone else called F.R. Carrick in research.
No, I think I'm the only one.
Yes.
Yeah, it'd be a pleasure if people read and they have questions. We're always so pleased to talk to people about what we're doing. And our real goal is to get things that people can do for themselves, to make them autonomous. So that when you go to your doctor and he or she does something to help you, that's marvelous. But you really got to take the ball and you've got to run with it and enjoy the game. So hopefully doctors will learn some of the strategies that we're doing to empower people to be able to take care of themselves, to become partners in their own healthcare.
Digital medicine is part of the future.
I hope so.
Yeah.
I hope so.
Thank
It's
you
beautiful.
so much.